Now the factor 8 and the factor 9 genes, they are located in the X chromosome. So it is X-linked recessive disorder. And in all cases of X-linked recessive disorders, the females are the carriers and the males are the sufferers. This is common to all X-linked recessive disorders. So here is a diagram that showing how hemophilia is transmitted. A female who is a carrier is the mother and the father is a normal person and the mother is the carrier. So she has two X chromosomes. One X chromosome has the hemophilic gene and another X chromosome is normal, and in the normal father there is only X chromosome which is normal and another Y chromosome. So if the siblings of these two parents, one will be normal male child, one female will be normal female child, another male which has inherited this X chromosome will be the affected male child, will be affected by the hemophilia disorder, and another female child who will inherit this X chromosome will be the carrier female. And like this thing, this disorder will pass on through generations. So, like all X-linked disorders, there will be 25% normal male, 25% normal female, 25% affected male and 25% female carrier. And the disease severity, the disease severity is not same in all the families. It varies from family to family, but more or less remains constant in case of individual people and in the successive generations. And there is and the severity depends on the level of factor 8 and factor 9 in the blood, and it remains more or less unchanged throughout the life. Like a person who is having severe hemophilia in childhood will not get better and have mild hemophilia in adulthood. This thing doesn't occur. Now the classification. The classification is dependent on the level of factor 8 in the blood. It can be classified as severe, moderate and mild. Severe hemophilia, that refers to a factor level less than 1%. Less than 1% of the factor 8 level, this leads to severe hemophilia. And in case of severe hemophilia, you will find that bleeding after trivial injury or there may be spontaneous bleeding. Moderate hemophilia is where the factor 8 level is between 1 to 5%. Here there will be bleeding after minor injuries or occasional spontaneous bleedings, but not as much bleeding as in severe hemophilia. And mild hemophilia is like 6 to 30% of factor 8 in the blood, and here bleeding occurs following surgical trauma or surgical or dental procedures. Here spontaneous bleeding, if the factor is between 6 to 30%, then the spontaneous bleeding doesn't occur. It can only occur following trauma or surgical or dental procedures. More than 30%, usually it's considered as normal. Now the clinical features. The most common clinical feature of hemophilia is bleeding into the joints. Joints includes large joints like knees, knee joints, ankle joints, elbows. These are the most common size, the large joints. And when the child is like less than 6 months old and the baby cannot move around, then you cannot detect hemophilia because there will be no injury. The baby will roll on the bed and there will be no injury as such. But as soon as the child begins to crawl or walk, then the manifestations will come, and you can see the bleeding occur, and it occurs between 6 months to 15 years of age. And single joint bleed, there may be single joint bleed which will cause stiffness, swelling, pain in the joint. Now subacute hemarthrosis. Subacute means it's not an acute phase of bleeding, but repeated bleedings in the same joint cause this subacute hemarthrosis. It develops after repeated bleeding into the same joint. Repeated bleedings. And due to repeated bleedings, what happens? The synovium of the joint, you all know the structure of the joint. The synovium of the joints becomes inflamed due to repeated bleeding. There is hypertrophy, hyperplasia, and increased vascularity of the synovial membrane. And there is increased bleeding, and there is hemosiderosis in the joint. The hemoglobin of the intra-articular blood, gets degraded, and the iron is deposited in the joint space. This happens in the subacute hemarthrosis. The next is chronic arthropathy. Subacute hemarthrosis progressively converts into chronic arthropathy. In chronic arthropathy, there is progressive destruction of the joint or inflamed synovial, which is known as pannus. It begins to secrete the enzymes which begins to destroy the articular cartilage. Till the subacute phase, there was only the synovium which was involved. Now, in case of chronic arthropathy, the articular cartilage becomes to be destroyed by the enzymes. There is microfractures and cyst formation in the subchondral bone. And in the end stage arthropathy, there is fibrous contracture of the joints and disorganization of the articular surfaces. This is the chronic arthropathy, and then this is the end stage arthropathy. This occurs with a hemophilic joint, and hemophilic joint is the most common manifestation of hemophilia. Here is the picture depicting a normal joint and a hemophilic joint. Normally you see there are two bones and an intra-articular space and joint space, and there is the synovial lining, there is the cartilage, the joint surface is lined by the cartilage, and here is the bone, there is the synovial lining, joint capsule, and then the ligaments and the muscles. In case of hemophilic joint, what happens? See, there are formation of cysts in the bones. The synovial lining, see this is the synovial lining in a normal joint, and this is the synovial lining of a hemophilic joint. It has become inflamed and it has thickened. In comparison to this synovial joint, this synovial membrane has got thickened. There is destruction of the articular cartilage. There is formation of cysts in the bone, and the joint space, see here the joint space is so much and here is so little joint space. This thing happens in the hemophilic joint, and this is the normal joint. So you all can see the changes happening in the arthritic joint. Now, joint is not the only space where bleeding occurs. Bleeding also occurs in the muscle or soft tissue, but the muscle and soft tissue bleeds are much more less than the joint bleeding. The most common sites of muscular bleeding are the iliopsoas, cuff, upper arm and forearm, thigh, the shoulder area and buttocks. And bleeding in the muscles causes pain, swelling and muscle spasms. And due to And if the bleeding is more and there is formation of hematoma within the muscles, there will be nerve compression and contracture of the muscles. There are other sites of hemorrhage, they are less common. There may be abdominal hemorrhage, there may be GI tract hemorrhage. The most dangerous is the intracranial bleeds, which is life-threatening, and there may be bleeding around the vital structures in the neck. Now the management in a nutshell. Previously, fresh whole blood was used prior to 1950. It has evolved like from 1950 to 1964, plasma products came into use, and plasma products were used from 1950 to 1964. In 1964, cryoprecipitate came into use, and in the early 1970s, the factor concentrates came into use. Now the thing is that the use of these products have increased the longevity and the morbidity of the patient and improved the quality of the life. But all these products, as they are derived from blood, they carry the risk of transmitting the transfusion related infections like HIV, hepatitis and all those things. Today the recombinant products, the recombinant factor 8 and factor 9, they are available in the market, and recombinant therapy is preferred nowadays. And when a patient comes with hemophilia, you have to give some management for the symptoms only, because factors, you are replacing the factors, okay, but that does not give you the immediate systemic relief. So you have to give some analgesics, but you cannot give aspirin. Aspirin is strictly contraindicated in case of hemophilia. You can give other anti-inflammatory medications. You have to take good dental care so that it doesn't bleed from the mouth, and you have to educate the patient and the patient for lifelong management. Psychological counseling needs to be done, and you have to take care of the long-term and management of the musculoskeletal problems. And you have to counsel the family, and you have to teach them the importance of early factor replacement, and you have to take some precautions, like while you are riding bicycle or tricycle, you have to give the child a protective helmet. Sports, all kind of contact sports are discouraged. Swimming, like skiing, tennis, golf, baseball, bicycling, these are generally safe if not the factor is like less than 1%. In case of mild to moderate disease, you can do this kind of sports, and you have to be very careful about the footwear. Now this is the picture showing the joint bleed, how it looks. This is the knee joint of a hemophilic patient. This, you can see the swelling, you can see there the bleeding here, and you can see how the joint is swelled and red and inflamed. This is a picture of chronic joint bleed. This is a picture of subdural hematoma, which is very dangerous. And when you open the dura, you see this kind of hematoma in case of hemophilic. And there can be bleeding from anywhere. Like, see, this is a knee joint bleeding. This is a muscular bleeding in the chest. This is periorbital hemorrhage, subconjunctival hemorrhage. There is bleeding from the nose, and there is bleeding from the mouth also. So this is all about hemophilia you need to know at your level. There are many things about hemophilia. As you grow up, you will know more about them. Previously, it was used to call idiopathic thrombocytopenic purpura, but as we have come to know the pathophysiology of the disease, It has been named as immune thrombocytopenic purpura. So it is a disease, it is a purely autoimmune disorder, and the patient may present with mild symptoms like mucocutaneous bleeding or with severe symptoms like intracranial hemorrhage. It has got a wide range of presentation, and some patients may complain of fatigue and impaired quality of life like that, because the recurrent bleeding causes anemia, and that anemia will lead to fatigue. And ITP may be a primary condition and may be a secondary condition also. There are some drugs which may cause ITP. So, the secondary causes of thrombocytopenia. These are important. There is pseudo-thrombocytopenia. There is no symptom and it is completely an in vitro phenomena. There is more platelet aggregation in the peripheral blood smear, and repeat platelet count in saturated blood will give you the actual platelet count. In renal or liver disease, there are signs and symptoms which will match the clinical history of renal and liver disease, and renal and liver function tests can be done. There also you will find decreased thrombocytopenia, decreased platelet count, and by the word decreased platelet count, it means platelet count less than 1 lakh. The normal platelet count is 1.5 to 4.5 lakh, and by decreased platelet count, it is meant that it's less than 1 lakh. In myelodysplastic syndrome, in acute leukemia, there will be also very low platelet count, but there will be other cytopenias also. In case of immune thrombocytopenic purpura, there will be only decrease in platelet count, but if you come across myelodysplasia or acute leukemia, the peripheral blood will show pancytopenia, or in case of acute leukemia, there will be increase in the WBC count, and you will be able to see the blasts and all those things, and this will differentiate from leukemia and NDS from ITP. Aplastic anemia. In aplastic anemia, there will be thrombocytopenia, but there will be pancytopenia as well. There will be reduced RBC, WBC, platelets, everything. And in bone marrow aspirate or biopsy, we will also see the changes, that there will be reduction in the all three lineages will be there. And there are some genetic disorders like Barnard-Collier syndrome like that, and there will also be thrombocytopenia, but the peripheral blood smear will also show like abnormal neutrophils and like that, and there will be abnormal platelets also. The platelets shape and size will also be abnormal. And thrombotic thrombocytopenic purpura, there will be neurological and cardiac syndromes with that, and cystocytes will be there on peripheral smear. LDH levels will be elevated. This test will help you to differentiate between TTP and ITP. And heparin induced thrombocytopenia is one hit, and in case of hit, there will be history of venous thrombosis, and there will be history of treatment with heparin. So these are the causes of secondary thrombocytopenia. This doesn't come under immune thrombocytopenic purpura. These are the secondary causes of thrombocytopenia. The pathophysiology of ITP. It is not properly understood. You have already read about the structure of the platelet. The platelet have some glycoproteins on their surface. The two main glycoproteins are GP2B3A and GP1B9. These are the two main glycoproteins present on the platelet surface. And autoimmune antibodies, which are mostly IgG in nature, they are formed against these antibodies. And when these antibodies are formed, these antibodies coat the platelets, and the platelets are then destroyed by the abnormal T cells which are involved. Like see, there is cytotoxic. The cytotoxic T cells are involved. The regulatory T cells are also involved. Antibodies are produced against these platelets. These are IgG kind of antibodies. These antibodies target the platelet glycoproteins 2B3A and 1B9, and they get attached to the platelets. Then the macrophages, they engulf these antibody coated platelets and they phagocytose the platelets, and there is destruction of the platelets. And T helper cells also take part in this process. And in bone marrow, there are megakaryocytes. Megakaryocytes will be there, and in fact there will be increase in megakaryocytes. But due to attachment of these antibodies, the megakaryocyte will not function properly. In case of aplastic anemia, you will not see megakaryocytes. Megakaryocytes will be very rare. But in case of ITP, there will be large number of megakaryocytes, but all of the megakaryocytes will be rendered inactive. These antibodies will get attached to the megakaryocytes, and this platelet production will be hampered. And other cells also, like B cells and plasma cells, they are also involved in this process, and plasma cells are the cells which produce these antibodies against the platelets. This is in nutshell the pathophysiology of the immune thrombocytopenia. And already told that it is below 1 lakh 100K per cubic millimeter. And first of all, you have to rule out all the secondary causes of thrombocytopenia. And when it comes to investigating a patient, you have to investigate the peripheral blood smear of the patient. And first you have to exclude all the other secondary causes, then only you can diagnose as immune thrombocytopenia, and there is no specific test for that. And bone marrow examination, you can do a bone marrow examination, but bone marrow examination is not diagnostic. This is a peripheral smear. In this peripheral smear, you will see there are the RBCs, and only a single platelet you can there in a in a single field. And this is the bone marrow picture. You see there are so many megakaryocytes, but all the megakaryocytes are inactive. How do you know it's inactive? Normal megakaryocytes, in case of normal megakaryocyte, you will see the pseudopores, and the platelets will be coming out as pseudopores. So there are so many megakaryocytes, but none of them are showing the pseudopores and the platelets coming out of them. All these megakaryocytes are inactive megakaryocytes. If you do a bone marrow aspiration in case of ITP, you will find these many megakaryocytes, but all of them are these inactive megakaryocytes. And the peripheral blood smear, you will get like such 1 in 1 hyperfilled like megakaryocyte, this type of thing. These are the bone marrow pictures, but this is not specific to ITP. So this you can't say on the basis of this that this is ITP. You have to rule out the secondary causes as well. Someone is feeling sleepy. Now you have the treatment in a nutshell. First of all, you have, if the patient is on any kind of anticoagulant therapy or antiplatelet drugs, you have to withdraw the those drugs. And the mainstay of treatment is platelet transfusion. When if the platelet count is very much low, if it comes down like less than 20,000 or like that, you can go for a platelet transfusion. But again the same thing, the antibodies are already there, they will destroy these platelets as well. IV immunoglobulin is given in it, but the effect lasts for 1 to 2 weeks only, and IV immunoglobulin is given for serious bleeding and those with very low platelets like less than 10,000. If the platelet count is less than 10,000, that means there will be spontaneous bleeding anywhere, from mucosa, from skin, intradural hemorrhage, subdural hemorrhage, everywhere. And in case of there may be menorrhagia, and that can be treated with some antifibrinolytic agent or hormonal therapy, but these are all symptomatic management of the symptoms. These are not proper management. And the risk factors of bleeding in IDP is older age group and with a previous history of bleeding, and generally the older age group people, they use anticoagulants and platelet inhibitors for reasons like cardiac causes and all those things. So they are at high risk, and people who are of risk of trauma from daily activities, they are also high risk people. So you have to be careful about all these things. Now the main other treatments, and these are the mainstay of treatments, are glucocorticoids, immunomodulators, and as they are destroyed, as the platelets are destroyed in the spleen, so in case of chronic IDP, splenectomy is the treatment of choice. Now the types of ITP. What is acute ITP and what is chronic ITP? Acute ITP is which has lasted less than 3 months, and acute ITP occurs mainly in children, and it mostly follows a viral infection. It is a transient phase. Symptomatic and supportive therapy will cure the patient, and if the platelet count becomes low, you can give IV immunoglobulin. And chronic ITP, it mainly occurs in the older people, and in this case you will find that the person is having ITP for more than 12 months. In this case you have to go for glucocorticoids and the immunomodulators. IV immunoglobulin is mainly for the acute ITP and for children, and for chronic ITP you have to go for immunomodulators and immunomodulator drugs, and they are also in case of acute bleeding or if there is an acute emergency, you have to go for platelet transfusion and IV glucocorticoid therapy. So that's all about ITP.
It is getting activated to form plasmin. This plasmin is responsible for the breakdown of the blood clots. When there is a vessel injury, what happens? There is vasoconstriction. Within seconds, the platelets aggregate. They try to stop. On that platelet, what happens? There is fibrin deposition. So there is a thrombus or a plug formed. So when you want to break that, you have to make that insoluble fibrin into fibrin fragments, so that the thrombus that is formed, it breaks up. So it is not always that this is that we want the plugs. We want to break down the plugs also. When there is natural bleeding, then the plugs have to go and block the bleeding. But when a thrombus or emboli is formed, what will happen? We will try to break it. because that thrombus will go and block the vessels. Okay. So there is a blood vessel injury, vasoconstriction, platelet plug formation is there. The clotting factors get activated and there is fibrin deposition. As a result of which, what is formed? Thrombus. Plasminogen circulates both in the plasma and it is also in the fibrin bound form. We are more concerned with the fibrin bound form. Why? Because the fibrin bound plasmin is not inactivated by the antiplasmin. Okay. Tissue plasminogen activator inactivated by the plasminogen activator inhibitors 1 and 2. See, these are the drugs which causes the conversion of plasminogen to plasmin. Plasmin now helps the breakdown of fibrin to fibrin degradation products. As a result of which, what will happen? The thrombus that is formed will break down. Okay. Increase plasminogen to plasmin. It causes the degradation of fibrin into fibrin degradation product and the thrombi will dissolve. But this cannot happen when the thrombus is more than 3 days old. So you have to go for recanalization early. Within 3 days, you have to start this drug. Okay. So what are the drugs? Altiplase, streptokinase, urokinase. These are the drugs that are used for the breakdown of fibrin into the fibrin degradation products. What happens during the fibrinolytic therapy? The clot dissolves. As a result of which, a big thrombus will break down into small thrombi, small, which can again occlude the small vessels. So as a result of which, what we do? We also start the antiplatelet drugs along with the fibrinolytic drugs. Understood? Why do we give aspirin also when we give all these drugs? Big thrombus, blocking a vessel, we want to break down. So small thrombi will be formed. These thrombi will go and again block the small vessels. So what we'll do? We will also start the antiplatelet drugs, aspirin or the antithrombotic drugs like the heparin. So these are co-administered with the fibrinolytic drugs. Now fibrinolytics, what are they? Streptokinase, it binds the circulating plasminogen and then activates the plasminogen and it converts to plasmin and then there is fibrinolysis. But urokinase, it directly activates the plasminogen. Okay. Altipase, retiplase, tenecteplase, they also selectively activate the fibrin bound plasminogen. When you are giving these drugs, you have to remember that you are giving a loading dose and then a maintenance dose. Okay. You are giving a loading dose for a quicker onset of action and then a maintenance dose to retain the action. Okay. Streptokinase. Streptokinase, now it is not employed. It is obtained from the beta hemolytic streptococcus. Okay, group C. It is less effective in opening the occluded coronary arteries. Coronary heart block. Okay, coronary, when the coronary vessels get blocked, it is less active. It is also less used these days. We have to give a loading dose due to the presence of anti-streptococcal antibodies. You can only use it once in a patient. Why? Because antibodies will be formed. Next time when you give it, already the body has the antibodies. So this drug won't act. So in a full lifetime, a patient can be given only once. Okay. Why? Because antibodies will be formed. What is the ADR? It is antigenic. Why? We are getting it from a streptococcus bacteria. So it can cause hypersensitivity reactions and also anaphylaxis. There can be fever, hypotension and arrhythmias. Next drug is the urokinase. It was isolated from the human urine and Now we are preparing it commercially from the cultured human kidney cells, not used nowadays. Altiplase. This is a recombinant, this is produced by recombinant DNA technology. So the previous one, what was that? Streptokinase from the bacteria. Next one, urokinase from the human urine or kidney cells. The third one is by the recombinant DNA technology. So you can have a bulk production. It catalyzes the cleavage of endogenous plasminogen to generate the plasmin with moderate specificity for the fibrin bound. I told you we are targeting the fibrin bound plasminogen. There are two types of plasma and fibrin bound. We are targeting the fibrin bound. Okay. It has a short half-life. Okay. For that, we have to give a slow IV infusion. Slow IV infusion, and it also requires heparin co-administration. I told you, why do we need aspirin or a heparin co-administration? So in this drug, if you are giving this drug, you have to give a heparin co-administration. You have to administer heparin also. Aspirin is routinely given after establishing reperfusion by the recombinant plasma activator. Inactivated by the plasminogen activator inhibitor, it is expensive. What is the ADR? There is risk of bleeding, it is not antigenic, and there can be nausea, mild hypotension and fever. Where is it used? In cases of MI, myocardial infarction, in case of pulmonary embolism and ischemic stroke. In these diseases, there are thrombus clot formed, so we need to break it. If you break it, what will happen? There will be revascularization and the blood can flow easily through the vessels which is blocked. So we are using in myocardial infarction, in pulmonary embolism and in case of ischemic stroke. Okay. The other two drugs are retiplase and tenecteplase. Now retiplase has an advantage, it is longer acting. So far the drugs were short acting. Advantage, it is longer acting and there is faster reperfusion. There is decreased chance of bleeding. Altiplase, I told you, high risk of bleeding. This reduced bleeding. Dose adjustment needed in the case of liver and kidney patients, diseased patients. Next, tenecteplase. This is also highly selective for the fibrin bound plasminogen, longer duration of action, and there is faster action. These are the two advantages, longer action and fast action. Okay. What is the ADR that you have to remember? There can be a chance of cranial bleeding when you give that drug. What are the adverse effects? Bleeding or the hemorrhage. When you are breaking a clot, there is a vessel injury, there is bleeding, vasoconstriction, thrombus plug goes and clogs it. When you are breaking that clot, what is happening? Chance of bleeding also increases. So, there is chance of bleeding or hemorrhage. There can be allergic reactions, multiple microemboli. When a big emboli is breaking up, there can be multiple microemboli. These can go and lodge in different organs, vessels, okay? And there can be cardiac arrhythmia. Contraindications, very important, where you are not supposed to use it. কোথায় ইউজ করবে না? ইন্ট্রাক্রেনিয়াল হেমারেজ কারোর যদি আছে, আগে কোনোদিন ইন্ট্রাক্রেনিয়াল হেমারেজ হয়েছিল, ওই পেশেন্টকে দেবে না। ইস্কেমিক স্ট্রোক 3 মাসের মধ্যে হয়েছে কারোর, তাকে দেবে না। স্ট্রোক পেশেন্ট, তাকে দেবে না। হেড ইনজুরি ছিল উইদিন 3 মান্থস, দেবে না। ইন্ট্রাক্রেনিয়াল টিউমার বা ভাস্কুলার অ্যাবনর্মালিটি, you are not supposed to give fibrinolytics. If there is history of active bleeding, অনেক পেশেন্টের গাম ব্লিডিং এর হিস্ট্রি থাকে, you are not supposed to give it. তার মানে কিছু একটা ক্লটিং ফ্যাক্টর ডিফেক্ট আছে বা that patient is hemophilic, you are not supposed to give it. Patients receiving anticoagulants, you are not supposed to give it. পেপটিক আলসার যাদের আছে, আরো ব্লিডিং বাড়িয়ে দেবে। পেপটিক আলসারের উপরে অলরেডি একটা যদি লেয়ার তৈরি হয়ে আছে, ব্লিডিং বন্ধ আছে, if you are removing it, ব্লিডিং বেড়ে যাবে। পেপটিক আলসার পেশেন্টের হেমোপটিসিস নিয়ে আসবে, হেমাটিমেসিস নিয়ে আসবে। Any wound or recent fracture or tooth extraction যদি হয়েছে, you are not supposed to give. History of major surgery within 3 weeks, uncontrolled hypertension, and in pregnancy. These are the contraindications you have to remember. This is an important question that can come. What are the contraindications? Before giving the drug, you should know the contraindications, because if you are giving to these patients, you are messing up. That patient will die to bleed. He will go on bleeding. Okay. Now this is a graph showing antigenicity. बोललाम कार सबचेয়ে বেশি হবে? Three most commonly used drugs এর মধ্যে streptokinase, কারণ streptococcus থেকে আছে, তো antigenicity তার মধ্যে আছে। Fibrin specificity, alteplase আর urokinase এ আছে, streptokinase এ কম। So this is a drawback. We want more specific, and half life হচ্ছে streptokinase এর অনেক বেশি compared to the others. Uses কোথায় কোথায় ইউজ করা হয়? I told you the contraindications, কোথায় দেবে না, কোথায় দেবে এবারে। acute MI হয়েছে, myocardial infarction patient কে, okay, there must be a block somewhere, ওই জন্য ischemia হয়েছে, infarction হয়েছে, heart wave, what is infarction? Due to ischemia হয় কেন? Due to decreased blood flow to that cell. মায়োকার্ডিয়ামে যদি মায়োকার্ডিয়াম সেলসে যদি ইয়ে হয়ে যায়, ব্লাড ফ্লো কমে যায়, তাহলে তো ইসকিমিয়া হবে। ইসকিমিয়া থেকে তারপরে কি হবে? ইনফাকশন। মায়োকার্ডিয়াল ইনফাকশন হয়েছে, তার মানে কোথাও একটা ব্লকেজ আছে, ওই ব্লকেজটাকে খুলতে হবে, তাহলে ফাইব্রিনোলাইটিক্স দিয়ে খোলা হবে। ওকে, তাহলে অ্যাকিউট মায়োকার্ডিয়াল ইনফাকশন। পালমোনারি এম্বলিজম, পেরিফেরাল আর্টেরিয়াল অক্লুশন, লোকাল থ্রম্বোলাইসিস ইন কেস অফ anterior chamber of the eyes, acute thrombotic stroke, and deep vein thrombosis. These are the indications of fibrinolytic drugs. Now antifibrinolytics অনেক বেশি দিয়ে দিয়েছো, পেশেন্ট ব্লিড করছে বা অন্য কোনো কারণে ব্লিড করছে, then what you want? You want to stop the bleeding? In that case you have to give antifibrinolytics. তাকে ফিব্রিন থাকুক, ফিব্রিন থাকলে কি হবে? প্লেটলেট প্লাগটা, ফিব্রিন ইজ ইনসলিবল, প্লেটলেট প্লাগটাকে কি করবে? ইনসলিবল তৈরি করে রাখবে। ফিব্রিন যদি ডিগ্রেড হয়ে যায়, তাহলে প্লাগটাও ডিগ্রেড হয়ে যাবে, তাহলে আরো বেশি ব্লিডিং হবে। যদি কোনো পেশেন্ট আসছে যার অনেক বেশি ব্লিডিং হচ্ছে, then you want to have a plug that is insoluble, যেটা soluble হবে না, একটা insoluble plug দিলে তাহলে স্যার ব্লিডিংটাকে বন্ধ করবে। So in that case the antifibrinolytics are used. Okay, দুটোই ড্রাগ, epsilon amino caproic acid and what else? Tranexamic acid. নাম শুনেছো নিশ্চয়ই, ট্রানেক্সা, very common, tranexamic acid and epsilon amino caproic acid. It is to counteract the effect of fibrinolytic drugs. Overdose হয়ে গেছে, বোঝা যাচ্ছে, ব্লিডিং স্টার্ট হয়ে গেছে পেশেন্টের, নোজ ব্লিডিং, গাম ব্লিডিং, ইউ আর আন্ডারস্ট্যান্ডিং, ফিব্রিনোলাইটিক্স দিয়েছো, এবারে অ্যান্টিডোট দিতে হবে চারটা, তো অ্যান্টিফিব্রিনোলাইটিক্স। ইন হেমোফিলিয়াক পেশেন্ট, হেমোফিলিয়াকদের কি হয়? দে কাম উইথ রিপিটেড ব্লিডিং, জয়েন্ট ব্লিডিং হয়, গাম ব্লিডিং হয়, হেমাটোসিস হয়, তাহলে সেই পেশেন্টগুলোকে কি করবে? ইউ হ্যাভ টু স্টপ দ্য ব্লিডিং, তখন তাদের ব্লিডিং স্টপ করার জন্য ইউ গিভ দ্য antifibrinolytics, where you are not supposed to give in DIC patients and bleeding from the upper urinary tract. Upper urinary tract থেকে ব্লিডিং হচ্ছে, দিলে ক্লট হয়ে যাবে, তাহলে কি হবে? ইউরেটারাল অবস্ট্রাকশন হবে। আপার ইউরিনারি ট্র্যাক্ট, ক্লট তৈরি করতে চাইছো, ক্লট তৈরি হয়ে গেল, তো কি হয়ে যাবে? ইউরেটারাল অবস্ট্রাকশন হয়ে যাবে, that will lead to renal failure. Tranexamic acid, where do you use this tranexamic acid? Tranexa, pause নামে পাওয়া যায়, very common drug, pause, tablet, injection, pause. When there is fibrinolytic drug overdose, cardiopulmonary bypass, tonsillectomy কোন পেশেন্টের হয়েছে? হাইভি ভাস্কুলার এরিয়া, ব্লিডিং হচ্ছে টনসিলেক্টমির পরে, তাহলে you give that. In prostate surgery, tooth extraction, in the case of hemophiliac, কোন পেশেন্টের যদি মেনোরেজিয়া হয় তাকেও দেওয়া হয়, because there is excess bleeding, You have to stop that. So in case of menorrhagia also, recurrent epistaxis হচ্ছে, nose থেকে bleeding, vessels গুলো bleed করছে, and in also case of peptic ulcer, you give tranexamic acid. Now next we come to the antiplatelet. Platelet কাজ করে কি? Platelet হচ্ছে অ্যাক্টিভেট হলে অ্যাগ্রিগেশন হয়, প্লেটলেট অ্যাক্টিভেশন অ্যান্ড অ্যাগ্রিগেশন, আর ব্লিডিং বন্ধ করে। সো ইউ আর গিভিং অ্যান্টিপ্লেটলেট ড্রাগস। সি, এন্ডোথেলিয়াল ইনজুরি হয়েছে, দ্য প্লেটলেটস উইল রাশ, ওখানে যাবে, প্লেটলেটস অ্যাক্টিভেট হবে, অনেকগুলো রিসেপ্টরস বডিতে আছে প্লেটলেটসের, সেগুলো অ্যাক্টিভেটেড হয়ে যাবে যখন অ্যাগনিস্ট এসে বাইন্ড করবে। প্লেটলেট অ্যাক্টিভেশনের পরে কি হবে? প্লেটলেটস উইল অ্যাগ্রিগেট and it will try to stop the bleeding from the injured area. Okay, so that is the work of the antiplatelet drug. What? You will stop the platelet activation and aggregation. ঠিক আছে, আমাদের চাই না প্লেটলেটস দিয়ে অ্যাক্টিভেটেড হয় আর অ্যাগ্রিগেট করে। There are various receptors. See, ADP receptors, GP2B3A, এটাও সব পড়েছো এগুলো। Thrombotic receptors. Okay, these are the thromboxane A2 receptors. These are the receptors which are getting activated when the agonist is going and binding. As a result of this, causes platelet activation. Platelet activate হলে কি হবে? Aggregate করবে. So you don't want that. Now antiplatelet drugs. এক একটা গ্রুপের এক একটা ড্রাগে বলবো। থ্রম্বোক্সিন সিনথেসিস ইনহিবিটর, অ্যাসপিরিন শুনেছো তো? লো ডোজ অ্যাসপিরিন, ইকোস্পিরিন দেওয়া হয় পেশেন্টসদের, অনেকেই নাম শুনেছো। প্লেটলেট সাইক্লিক ইএমপি ইনহ্যান্সার, মানে সাইক্লিক ইএমপিটাকে ইনক্রিজ করে রাখছে লেভেলটাকে। P2Y12 receptor blocker, this is a receptor that is present in the outer layer of the platelet. And GP2B3A, this receptor is also present in the outer walls of the platelet. Now low dose aspirin. Low dose aspirin is used as an antiplatelet drug, or high dose aspirin is used as an NSAID. Okay. Mechanism of action. Low dose যখন দিচ্ছ, it will selectively, irreversibly, this is a very important, irreversibly it will go and inhibit the cyclooxygenase 1 that is present in the platelet. Cyclooxygenase কি করে? তৈরি করে cyclic endoperoxides that leads to thromboxane A2. Thromboxane যখন prostaglandins আর এগুলো পড়া হয়েছিল cyclooxygenase, তখন বলা হয়েছিল থ্রম্বোক্সিন কি করে? প্লেটলেট অ্যাগ্রিগেট করে, আর প্রোস্টাসাইক্লিন কি করে? ভেসোডাইলেট করে প্লেটলেটকে ফ্রি ফল, ইনহিবিটস দ্য অ্যাগ্রিগেশন। ওকে, তাহলে থ্রম্বোক্সিনকে যদি কমিয়ে দিচ্ছ, তাহলে কি করছো? প্লেটলেট অ্যাগ্রিগেশনকে কমিয়ে দিচ্ছি। তো সাইক্লোক্সিজিনেস যেটা থ্রম্বোক্সিন A2 সিনথেসিস করে, আমরা তাকেই ইনহিবিট করে দিচ্ছি। So there is no more synthesis of thromboxane A2 which is responsible for platelet aggregation. Okay, so there is decreased thromboembolism. 7 to 10 days before surgery aspirin বন্ধ করে দেওয়া হয়, কেন? ব্লিডিং করাবে। ওকে, আরেকটা, why 7 to 10 days? প্লেটলেটের হাফ লাইফ কত? ইররিভার্সিবলি অ্যাক্ট করে, 7 to 10 days টাইম লাগবে। প্লেটলেট তৈরি হয়েছে, হাফ লাইফ অফ দ্য প্লেটলেট কত? 7 দিন লাগে। আরবিসি কত ছিল মনে আছে? 120 days। প্লেটলেট কত দিনে হয় তৈরি? একটা সাইকেল 7 to 10 days। ওকে, এবারে যতক্ষণ না নতুন প্লেটলেট আসছে, ততক্ষণ নতুন সাইক্লোক্সিজিনেস আসছে না, বিকজ অ্যাসপিরিন ইন দ্য লো ডোজ ইজ ইররিভার্সিবলি ইনহিবিটিং, ওই প্লেটলেটটার আর কাজ হচ্ছে না। এবারে যতক্ষণ না নতুন প্লেটলেট আসছে, ততক্ষণ কাজ হবে না। আন্ডারস্টুড? It is given only once a day and most common use is prophylaxis of MI patient. যদি কোনো MI patient থাকে, তাকে আমরা অ্যাসপিরিন দিয়ে রাখি, low dose aspirin, that is prophylaxis. Dipyridamole, It is a platelet cyclic AMP enhancer. Cyclic AMP যদি enhanced থাকে মানে বেশি থাকে তাহলে কি হবে, প্লেটলেট অ্যাক্টিভেট হবে না, তাহলে সাইক্লিক এএমপি কে আমরা ডিগ্রেড হতেই দেবো না। ওকে, inhibits the phosphodiesterase or by blocking the uptake of adenosine it increases the concentration of cyclic AMP. cyclic AMP কে ব্রেকডাউন হতে দিচ্ছে না। cyclic AMP ব্রেকডাউন কে করে? phosphodiesterase enzyme breaks down cyclic AMP. ওকে, আমরা আইদার ব্রেকডাউন করতে দেবো না বা আপটেক করব না, তাহলে ইনক্রিজ অফ দ্য লেভেল অফ দ্য কনসেন্ট্রেশন অফ হোয়াট, অফ cyclic AMP. When cyclic AMP is high, there is decreased calcium which will interfere with the platelet function. cyclic AMP যদি কমে প্লেটলেট অ্যাক্টিভেট হবে, cyclic AMP যদি বেশি থাকে প্লেটলেট অ্যাক্টিভেট হবে না। প্লেটলেট অ্যাক্টিভেট না হলে কি হবে, প্লেটলেট অ্যাক্টিভেট হবে না, রিলিজ করবে না, প্লেটলেট রিলিজ অ্যাকশন হবে না, অ্যাগ্রিগেশন হবে না। ওকে, কোথায় ইউজ করা হয়? It is used with warfarin to decrease the embolization in prosthetic heart valves. যেখানে prosthetic heart valves placement করা হয় সেখানেই আমরা ইউজ করি। ওকে, coronary stent phenomena ডাইপাইরিডোমোলের অনেক ইম্পর্টেন্ট, কার্ডিওলজিতে করা হয়েছে, হ্যাঁ অ্যানজাইনাতে পড়ানো হবে, কার্ডিওলজি পার্টে ওটা পড়ানো হয়েছে, হয়ে গেছে। So dipyridamole is a vasodilator which was actually introduced as an anti-anginal drug because of the coronary steal phenomena, but it can also be used as an antiplatelet drug. It can also be used for secondary prevention in patients with the transient ischemic attack. যাদের বারবার ischemic attack হচ্ছে transient which is lasting for few seconds, ওই পেশেন্ট গুলোকেও ইউজ করা হয়। low dose aspirin is given to those patients. প্লেটলেটের বডিতে আরেকটা রিসেপ্টর থাকে, এডিপি রিসেপ্টরস। ওকে, these are purine receptors, two types, P2Y1 and Y12. We are concerned with the Y12. Y12 টা কি করে? resulting in the decrease in the intracellular cyclic AMP, যেটা বললাম cyclic AMP বেশি থাকলে প্লেটলেট অ্যাক্টিভেট হবে না। now decrease in the cyclic AMP, platelet will get activated. so we are concerned with this, we are blocking this receptor, তাহলে cyclic AMP ডাউন হবে না, তাহলে প্লেটলেট অ্যাক্টিভেশন হবে না। ক্লিয়ার? ভেরি ইম্পর্টেন্ট ড্রাগ ক্লোপিডোগ্রেল। অ্যাসপিরিনের সঙ্গে অনেক সময় কি করা হয়, ডুয়াল অ্যান্টিপ্লেটলেট দেওয়া হয়, অ্যাসপিরিন এন্ড ক্লোপিডোগ্রেল। হ্যাভ ইউ হার্ড? চেস্ট পেন নিয়ে পেশেন্ট আসে, হাই লোডিং ডোজে কি দেওয়া হয়, অ্যাসপিরিন, ক্লোপিডোগ্রেল। ওকে, সো ক্লোপিডোগ্রেল is a P2Y12 receptor blocker. ড্রাগ ইন্টারাকশন মনে রাখতে হবে, প্রোটন পাম্প ইনহিবিটর যদি কোনো পেশেন্ট নিচ্ছে, প্রোটন পাম্প ইনহিবিটর ওমিপ্রাজোল, প্যান্টোপ্রাজোল, সেই পেশেন্টটাকে যেন ক্লোপিডোগ্রেল দেওয়া হবে না, প্রোফাইল্যাক্সিস। ওয়াই? বিকজ ক্লোপিডোগ্রেল ইজ আ প্রো ড্রাগ, অ্যাক্টিভেট হতে হবে। কে অ্যাক্টিভেট করবে? CYP 219। তাহলে কি হবে? আর ওমিপ্রাজোল কি করে? এটাকে ইনহিবিট করে। ওকে, proton pump inhibitors like omeprazole, CYP 219 inhibition, হ্যাঁ হ্যাঁ ওটা ইয়ে হয়েছে, মিস্টেক হয়েছে। so that will decrease the conversion and it will decrease the and it will also decrease the efficacy. ঠিক আছে, CYP 3A4 ও আছে, ঠিক আছে। what are the adverse effects? bleeding হতে পারে, there can be thrombotic thrombocytopenic TTP, purpura যেটা বলে, neutropenia and thrombocytopenia. so these are the only the important points I am telling, what you have to remember. একটা মেকানিজম মনে রাখতে হবে, একটা ড্রাগ ইন্টারাকশন মনে রাখতে হবে। পিপিআই এর সঙ্গে ক্লোপিডোগ্রেল দেওয়া যাবে না, আর কি কি অ্যাডভার্স ড্রাগ রিঅ্যাকশনস হতে পারে? What are the uses? Same, stroke, myocardial infarction. Okay, after coronary stent, implantation, clopidogrel is used. Same, myocardial infarction হলো, stroke, তারপরে পেশেন্টস গুলোকে এগুলো দেওয়া হয়। নেক্সট নিউয়ার ড্রাগ, দ্যাট ইজ প্রাসুগ্রেল। ক্লোপিডোগ্রেল এর পরে নিউয়ার ড্রাগ এলো। ওকে, অ্যাডভান্টেজেস কি কি? That is rapid onset of action and the incidence of the cardiovascular death is decreased. Incidence of stent thrombosis also decreases. So this was the advantage. Next drug, ticagrelor. Advantage, it can be given orally, twice daily dosing. Advantage হচ্ছে rapid onset of action, greater and more predictable inhibition of the platelet aggregation. Last group, glycoprotein 2B3A receptor antagonist. Now this is a receptor that is present on the platelet surface. Okay, what are the agonists? For fibrinogen and von Willebrand factor. These are coming binding with the help of these receptors. Okay, and it finally causes the platelet aggregation. If you give antagonist, then you can block the platelet aggregation. What are the drugs? Abciximab is used. It is a chimeric drug. 25% of the mice and 75% of the human tissues used. So important part. Chimeric drug kake bole? 25% mice and 75% of the human tissue used. It is relatively non-specific and binds to some other surface proteins also. This is a disadvantage. The half-life is 30 minutes, but the action it lasts for very long. What is the disadvantage? It is very expensive. What are the other drugs on this group? Abciximab, eptifibatide and tirofiban. These are the drugs. But abciximab is used commonly. So this is all for today. Plasma expander already hoye geche. So we have studied fibrinolytics.
I discussed about the different types of myeloid neoplasm. It could be acute one, could be myeloproliferative disorder, could be myelodysplastic, could be myelodysplastic myeloproliferative, MDS, MPN combined, and could be other classification. So it is a part of, so you have to know the CML না, মানে তোমাদের কোনো থিওরি ক্লাস নাই, মানে তোমাদের হচ্ছে ডিওপি তেই তোমাকে কভার করতে হবে। ওকে, so it is included in the topic of myeloproliferative disorder, MPD, or myeloproliferative actually neoplasm, MPN. So what are the other types of myeloproliferative neoplasm? Can you say other names, other what are the other diseases which are included within the myeloproliferative neoplasm? No, that's a lymphoid one, it's not a myeloid one. Anyone? Have you heard some name like polycythemia vera, essential thrombocytosis, essential myelofibrosis, or primary myelofibrosis? I'm writing in a short. So polycythemia, essential thrombocytosis, and primary myelofibrosis. And another one, chronic myelomonocytic leukemia. Okay. There are so many other topics, but these are the major topics which are included in the myeloproliferative neoplasm. So this is a whole scenario where the precursor forms of myeloid series increases either within the bone marrow or within the blood. Okay. So if the myeloid lineage in pluripotent niche can be divided into, or they actually committed into, mainly three types: granulocyte series, erythroid series, and thrombocytic or megakaryocytic, that is megakaryocytic series. And there are another component of pluripotent myeloid series, which is fibroblast and stroma. So if the myeloproliferative neoplasm arises from granulocyte series, it is known as CML. Then essential thrombocytosis and myelofibroblast and stromal cell primary myelofibrosis. Clear হয়েছে আইডিয়াটা? So all the precursor cells basically included in CML are from granulocyte series. Granulocyte series এর ফুল লেন্থে যা যা precursor cell থাকবে তুমি CML এ সেটা দেখতে পাবে। This acute leukemia, acute myeloid leukemia, and this two terms, that is these two disease, polycythemia vera and essential thrombocytosis, they go into stage of, at the later half of the disease, with the progression of the disease course, they go into stage of primary myelofibrosis. Clear হয়েছে আইডিয়াটা? Polycythemia vera and essential thrombocytosis, with the progression of the disease course or in the later half of their disease, they usually progress to primary myelofibrosis stage. And the CML, with the advancement of the disease, they may go into stage. They actually go, of course, most of these cases, these are diagnosed in the chronic stage, but there are mainly three stages. I will come later in this half. But that CML go into stage of AML in the later time. Reciprocal translocation. What do you mean by reciprocal translocation? I think all of you have come across this term, reciprocal translocation. A segment of chromosome get detached from its original site, and it is translocated to another loci and fused with another part of segment of chromosome, and it forms a chimeric chromosome 1. This CML caused due to reciprocal translocation of chromosome 9 and chromosome 22, which is known as translocation 922. So this ABL gene gets detached from its normal loci of chromosome 9, and it gets fused with GCR at short of 20. And this fusion gene is known as ABL BCR fusion. This fusion chimeric gene has an intrinsic tyrosine kinase activity, which is normally in a what can I say? The normal stage, the proliferation of different different components of granulocyte will be within a normal level. But this gene product form excessive activity of tyrosine kinase, which causes increased proliferation of different component of granulocytes. Precursors of granulocytes. So this ABL-BCR fusion can be diagnosed even in peripheral blood with the help of a technique known as FISH. This FISH can diagnose this ABL-BCR fusion gene in the blood. This ABL-BCR fusion gene has two types of protein product, which is known. One is 10 kilodalton protein product, and one is 191 kilodalton protein product. This 10 kilodalton protein product usually in 90% cases of CML causing the increase in intrinsic activity of tyrosine kinase. And this 190 kilodalton protein product usually in 70% cases of ALL acute leukocytic leukemia, and also 8 to 10% cases of atypical CML. These are associated with 190 kilodalton protein product. Key inferences data utility. This 210 kilodalton protein product in CML has a very good prognosis on normal classical chronic thyroid, because against this protein product a very important targeted therapy has been designed. It is known as neotenib, dasatinib, and its precursor is methylate. Neotenib, methylate, or dasatinib is important protein product against the 10 kilodalton protein. A designed targeted therapy is present, and it will cause a very good remission in CML. But if it is a 190 kilodalton protein product, it carries a dismal prognosis in acute neotenib, dasatinib. These are monoclonal antibodies against the tyrosine, ABL, BCR protein gene product tyrosine kinase. These monoclonal antibodies are designed against ABL, BCR product tyrosine kinase. যার জন্য আমাদের খুব ইম্পর্টেন্ট এই BCR ABL1 BCR ABL1 not ABL1 protein product ঠিক আছে, এটা আমাদের প্যাথোজেনেসিস অফ সিএমএল ক্লিয়ার আছে। টু ইনোভেটিভ অ্যান্ড মলিকুলার জেনেটিক্স। আমি যখন প্যাথোজেনেসিস নিয়ে কাজ করব, then we are discussing basically about cytogenetics and molecular genetics. The cytogenetics is transformation at 922, molecular genetics is ABL-BCL1 mutation. So what are the clinical features? Before coming into clinical features, we have to categorize the CML according to three major phases. One is chronic, one is accelerated, blast crisis. And another is blast crisis. About 80% cases are diagnosed in chronic stage. 15% cases are diagnosed in accelerated stage, and 5% cases are diagnosed in blast stage. So, which is the most important distinction between chronic, accelerated, and blast crisis? Of course, yes, one feature is visible. That was the most important. Differentiating point is blast. In case of chronic, it is usually less than 2%, according to 2022 modification. WHO it is 2%. 2 to 20%. And more than 20%, it's basically behave like anemia. Why? Because these blasts are positive for CD, marker of myeloid cells. That is CD. CD. Next. So this blast are positive for this 4 important myeloid series markers. Here, this is the we should talk about the chronic phase first, because this is the in the chronic phase around 80% cases are diagnosed. So which is the what are the clinical features of chronic phases of chronic myeloid? The usual age of presentation 40 to 50 years with slight male and female preponderance. They basically causing the increased proliferation of different granulocyte precursors within the marrow. So, there will be almost 90 to 100% bone marrow is infiltrated with different precursor, myeloid precursor. As a result, there will be decrease in erythroid and megakaryocyte precursor. Cytogenetics. যদি erythroid precursor decrease করে কি প্রেজেন্ট করবে? myeloid precursor decrease করলে depleted right? Megakaryocyte. तो megakaryocyte bleeding. Proliferation of bone marrow, excessive proliferation of precursor within the bone marrow. So there will be hematolymphoids, bone marrow, extracellular, and of course the extra-hematopoietic bone marrow proliferation. As a result, in the clinical feature, they will present with hepatosplenomegaly and of course cervical lymphadenopathy and other extra hematopoietic bone marrow proliferation. As a result of this kind of hematopoietic bone marrow proliferation, there will be startle tenderness and tenderness over the different flat bone. And in atypical cases, there will be thrombocytosis. Thrombocytosis in
কেন হচ্ছে জিজ্ঞেস করব সেটা জানতে চাইলে এটা আমাদের সিলেবাসে নাই চাইলে বলবো অবশ্যই so these are the main clinical features blood features are presence of blast less than 20%, 2% sorry, increased number of myelocytes and beta myelocytes and the basophil level in chronic states. Please should be 15-20%. These are the most important and full range of different precursors of myeloid cells. Can you see? এটা কি বলো জিনিস না এটা কি what are the precursor cells of myeloid cells of course eosinophil and eosinophil precursor axial and basophil precursor and of course there are some monocytes but a monocyte is important monocytes are usually less than usually in case of CML that is chronic phase of CML is usually less than so we have to identify these things there might be very increased number of eosinophil and eosinophil precursor abundant cytoplasm basic chromatin a small number of tabule granules but nucleoli are not so prominent if the nuclei is prominent and the cytoplasm is relatively low less in promyelocytes brick shaped color is getting proliferated in precursor. This is also eosinophil precursor. Neutrophil brick এটা খুব একটা ভালো করে আছে লাইট অফ করো আমারটা
কোষ গ্র্যানিউলে পুরো সাইটোপ্লাজম ভর্তি হয়ে আছে বেসোফিল এখানে দেখো খুব ক্লাম্প সাইটোপ্লাজমটা অনেকটা হাই কোনো গ্র্যানিউল নেই and cell is shorter no nucleated RBC this is nucleated RBC or late normoblast myelocyte metamyelocyte meta two band meta myelo neutrophil এটা কি মাইলোসাইট এটা কি monocyte this is monocyte but promonocyte monocyte is just আগের stage promonocyte nuclei acidophilic granules is low in number relatively small amount of cytoplasm নেই তেমন অত নেই promyelocyte this is promyelocyte ঠিক আছে so this is the basically bone marrow features PBS peripheral blood leukemia এটা প্রোলিম্ফোসাইট মিরর সেল বলা হয় প্রোলিম্ফোসাইটের এরকম একটা হ্যান্ডেল মিররের হ্যান্ডেলের মতন বলা মিরর সেল বলা হয় বেসোফিল প্রিকাসর হ্যাঁ মাইলোসাইট মাইলো, এটা মেটা, ওটা মেটা, ম্যাচিউর মেটা, এটসেট্রা। এটাকে বলা হয় সিউডো পেলগার হিউট। হ্যাঁ, সিউডো পেলগার হিউট। এমডিএস এ পেলগার হিউট অ্যানোমালি হচ্ছে একটা সেপারেট অ্যানোমালি, বাট এমডিএস বা এনপিএন এ সিউডো পেলগার হিউট। বাইল লব, হ্যাঁ আরো ভালো আমি দেখাচ্ছি। দুটো লোব আলাদা নেই, ঠিক আছে, জাস্ট ডিসপ্লাস্টিক মনে হচ্ছে দেখে, বাট নট আ আন্ডারলাইং প্যাথোলজি আছে যেটা পেলগার হিউটে থাকে। বোন ম্যারোতে আর একটা সেল পাওয়া যাবে। অ্যাপার্ট ফ্রম দ্যাট the bone marrow features are slightly different because within the bone marrow the eosinophil precursors are usually a bit high in number, and there will be some clustering of megakaryocyte in bone marrow. The fat material within the bone marrow is totally replaced by immature precursor cell, and there will be some cells like this type of feature. The cytoplasm will be sea blue in color. Within the cytoplasm, some vacuoles will be there and some granules will be there. A huge cell within a cytoplasm. The cytoplasm will be sea blue in color, and within the cytoplasm there will be vacuole and granules. Okay, this is known as pseudo Gaucher cells. Pseudo Gaucher cells. Gaucher cell যে সাইটোপ্লাজম থাকবে সেটা বা নিউক্লিয়াস থাকবে সেটা হচ্ছে ক্রাম্পলড টিস্যু পেপার অ্যাপিয়ারেন্স হবে, ক্রাম্পলড টিস্যু পেপার অ্যাপিয়ারেন্স। বাট এই নিউক্লিয়াসটা এরকম নয়, অনেক ক্লাম্প হবে। হ্যাঁ, কোনটা কি স্টোরেজ বলো? গ্লাইকোজেন স্টোরেজ ডিসঅর্ডারে Gaucher cells পাওয়া যায়, but pseudo Gaucher cells will be present in CML. In chronic phase, difference totally আলাদা। এটা হচ্ছে, এটা বেসিক্যালি একটা টিস্যু ম্যাক্রোফাজ। There will be high turnover of premature precursor cells, myeloid precursor cells, and these fragments of turnover myeloid precursor cells are engulfed by tissue macrophages. That's why there will be some phagosome within the cytoplasm and so many granules within the cytoplasm. This is known as pseudo Gaucher cell. In chronic phase, the NAP score will be low. It will be 0 to 20 because the normal NAP score is 40 to 100, but in CML the NAP score will be low. So these are the main features, peripheral blood smear and bone marrow features of chronic myeloid leukemia. Now in accelerated stage, what are or criteria for accelerated stage according to WHO? কি হবে? There will be প্লাস তাড়াতাড়ি বল, তাড়াতাড়ি শেষ করি, হ্যাজাবো না, বেশি হ্যাডস নামাবো না। 10 to 20% বেসোফিল more than 20%. There is two terms, thrombocytosis and thrombocytopenia. Presence of presence of platelet more than 10 lakh, which is এই পয়েন্টটা মনে রাখো প্লিজ, presence of platelet more than 10 lakh which is not which is not this is not getting response from treatment, or thrombocytopenia, that is presence of platelets less than 10,000, which is unrelated to the treatment. কি বুঝলে? There are two features: presence of platelet more than 10 lakh, which is unresponsive to the treatment. Treatment দিয়েও 10 lakh প্লেটলেট কে নামানো যাবে না, or আরেকটা সিনারিও হতে পারে platelet count is less than 10,000, which is not due to treatment part. And persistent splenomegaly. So these are criteria. Hyperviscosity এমনিও হয়। hyperviscosity syndrome আলাদা পড়াবো, আমি এখন এর মধ্যে পড়াবো না। Thrombocytopenia, that is less than 10,000, which is unrelated to the treatment, or thrombocytis which is unresponsive to the treatment, and persistent splenomegaly. So these are features of accelerated stage of CML. But when it go into worse stage, I mean আরো খারাপ যখন যাচ্ছে, that go into stage of AML. So what are the similar kind of, I mean differential diagnostic criteria, মানে what are the differential diagnosis of CML? তোমাদের যখন কোয়েশ্চেন আসবে, তোমাদের কোয়েশ্চেন এরকম করে আসবে, তোমাদের ক্লিনিক্যাল ফিচার একটা আসবে, সেই ক্লিনিক্যাল ফিচারের মধ্যে 40 years male patient presented with full fledged of anemia, repeated bleeding, nasal bleeding, GI bleeding, petechiae, echinosis, etc., etc. On clinical examination, patient having hepatosplenomegaly and cervical lymphadenopathy. On examination, there will be sternal tenderness. What might be your clinical, I mean professional diagnosis? Of course, CML. What other causes may look similar like CML? So what are the differential diagnosis of CML? CMML, এই দুটো টপিকই তোমাদের সিলেবাসে নেই, but CMML is included in broad category of MDS MPN, and দুটো করে ফিচার মনে রাখো। ক্রনিক মাইলোমোনোসাইটিক লিউকেমিয়ার ক্ষেত্রে myeloblasts will be less than 20%, but there will be excessive, I mean high amount in monocyte and monocyte precursor, chronic myelomonocytic leukemia. And of course, this is not related to translocation 922. মাইলোমোনোসাইটিক দুটো প্রিকারসারই আছে, এবং both are dysplastic precursor. Dysplastic cells are getting proliferated here. Okay, and atypical CML. Atypical CML এ of course translocation 922 হবে, but there will be dysplastic granulocyte, and the blast cell will be more than 2% but less than 20%. Chronic myelomonocytic leukemia তে যেমন ট্রান্সলোকেশন 1922 নেগেটিভ ছিল, atypical CML it will be positive, but the granulocyte will be dysplastic and the blast cell will be more than 2%, and of course it is less than 20%. বোঝানো গেল? Positive for Translocation 922. Main therapy against the tyrosine kinase activity, imatinib, mesylate, dasatinib, nilotinib, etc. Main mode of therapy. ব্যাস এইটুকুই বোধহয় জানো, এটা বেশি তোমাদের জানার দরকার নেই সিএমএল এর ক্ষেত্রে। আচ্ছা, আর একটা টপিক তোমাদের আছে, সেটা হচ্ছে CLL, chronic lymphocytic leukemia. One is B lymphocyte, another is T lymphocyte, and another is NK cell. This B and T lymphocyte, B lymphocyte further mainly of two types, pre-B cell and mature B cell. Okay, T lymphocyte are also two types, precursor B cell, T cell, and mature T cell, and of course there is NK cell. So any neoplasm originating from precursor B and precursor T cell are known as acute lymphoblastic leukemia, and this mature B cell, if any kind of neoplasm occurring from mature B cell, that might be Hodgkin lymphoma. Mature B cell go into stage of plasma cell, so plasma cell dysplasia, and non-Hodgkin lymphoma. Of course, the T cell, from T cell, mature T cell, most of them different type of non-Hodgkin lymphoma of T cell, and precursor NK cell, different type of NHL. A non-Hodgkin lymphoma, which is basically arising from mature T cell, one of the example is CLL. Clear হয়েছে? CLL. One of the example is CLL. Basically এই কোশ্চেনটা অবশ্যই মনে রাখো, it will be your MCQ. Next one, anything arise from post germinal center mature B lymphocyte. Post germinal center mature B, post germinal center mature B lymphocyte. যখনই when we are talking about this post germinal center, তোমরা যখন একটু বড় হবে, মানে ছোট আছে এখনো, স্টিল বয়স যাই হোক, তখনই পোস্ট জার্মিনাল সেন্টার কথাটা যখনই তোমাদের মাথায় আসবে, তখনই দুটো মার্কারের কথা অবশ্যই মাথায় রাখবে, CD5 and CD23. Okay, but this CD5 also positive in mantle cell lymphoma, because it is also a marker of post germinal center. মানে কি, তোমাদের লিম্ফোড নোড পড়ানো হয়েছে কি হয়নি? হ্যাঁ, তাহলে বলো, what are the structures of lymph node? লিম্ফ নোডের স্ট্রাকচার না জানলে বেসিক্যালি লিম্ফোমার কোনো ক্লাসিফিকেশনই তোমাদের মাথায় আসবে না। This is lymph node. Suppose this is lymph node, this is cortex, and this is medulla. Okay, okay, this is lymph node, this is cortex, and classified into two zones anatomically. There should be a medulla and there is the cortex. There will be aggregates of lymphoid cells within it, and this aggregates, within the aggregates there will be formation of germinal center. The germinal center basically of two types, primary and secondary. Within the secondary germinal center there will be presence of some follicular dendritic cell. Within the germinal center, if the follicular dendritic cells are present, then this is known as secondary germinal center. Around the germinal center, there is a zone where some set of lymphocytes present in high number. These are CD5 lymphocytes, and there are some small light chain rearrangement of that CD5 lymphocytes. These are known as mantle zone. And between this mantle zone, there are some sinusoids, of course, and surrounding this sinusoids, there will be a place which is known as marginal zone. So T lymphocytes, and this, of course, the sinusoids enter through the cortex and pass to medulla. So around this sinusoids, in parafollicular area, there might be T cell, and also in medulla there might be T cell. But apart from that, there are different types of B cells. So if the lymphoma arises from this germinal center, that will be follicular lymphoma or DLBCL, diffuse large B cell lymphoma. If it is arise from mantle zone, then mantle cell lymphoma. If it is arise from marginal zone, then marginal zone lymphoma. And of course, it might arise from T lymphocytes, so T lymphocytic leukemia, lymphoma. So from this marginal zone, of course, within the marginal zone, mantle zone, within the mantle zone, there is some post-germinal center B mature B cell where the immunoglobulin heavy chain rearrangement already has been occurred, and that from that cell CLL, chronic lymphocytic leukemia, lymphoma arises. This is in nutshell এইটুকু concept মাথায় রাখো please, তোমাদের জন্য এইটুকু concept enough. Marker is CD5 and marginal zone lymphoma cyclin D1. Okay, and T cell marker is CD3, CD4, CD8, and of course this is CD5 also positive in some cases. ওটা পরে হচ্ছে হলো, বোঝা গেল? The origin of lymphocytic leukemia, chronic lymphocytic leukemia. So if I classify the chronic lymphocytic leukemia, lymphoma, that can be classified in mainly three categories. CLL proper, second CLL PLL, and 3 PLL. CLL proper means বলছি, আমি PLL ফুল ফর্মটা বলি, প্রো লিম্ফোসাইটিক লিউকিমিয়া। That is overlapping of chronic lymphocytic leukemia, pro-lymphocytic leukemia, and there is pro-lymphocytic leukemia. তার আগে আমাকে জানতে হবে CLL এ অ্যাকচুয়ালি কি পাওয়া যায়? This is basically clonal proliferation of mature lymphocyte, and there might be more than, there is, of course this is the criteria, more than of mature B cell will be there within the bone marrow, and the absolute lymphocyte count will be more than 5000 per cubic millimeter, cubic micron, 5000 per microliter of blood. Okay, and atypical lymphocyte দেখাচ্ছি, atypical lymphocyte in case of CLL, in case of CLL will be less than 10%, will be less than 10%. So this is the main important criteria by which the CLL, PLL and PLL can be differentiated. In the CLL it will be less than 10%. In CLL, PLL it is 10 to 5%, 55% of pro-lymphocyte, but in PLL there will be more than 55% of pro-lymphocyte. 10%. CLL, PLL pro-lymphocyte is 10 to 55%, and in PLL the pro-lymphocyte is more than 55%. ওকে, এইটা ক্রাইটেরিয়া। তাহলে দুটো ক্রাইটেরিয়া বললাম, আরো অনেক ক্রাইটেরিয়া আছে, বাট দুটো ক্রাইটেরিয়া মনে রাখো, ক্রনিক লিম্ফোসাইটিক লিউকেমিয়া বা লিম্ফোমাতে কিছু করার নেই। এর পরের দিন আমি এটা পড়াতে পারবো না। or mediastinal or etc lymphadenopathy. The usual age of presentation is around 50, and here also the male preponderance is high, but the important feature is it is very indolent case, indolent, খুব gradually progress করে, and there will be two important features which is related to the CLL. One is autoimmune hemolytic anemia, and another is autoimmune thrombocytopenia. Due to presence of autoimmune immunoglobulin antibody, which is present within the abnormal clonal proliferated cells. In the surface of the clonal proliferated cells, abnormal autoimmune antibodies are present. These antibodies are present basically against this RBCN platelet, and they cause the autoimmune hemolytic anemia and thrombocytopenia. If these both conditions present all together, একসঙ্গে যদি থাকে, this is known as Evans syndrome. Okay, Evans syndrome. প্রফেসর ক্রিস ইভানসন, লুই ক্রিস ইভানসন নামে, উনারও নাম ছিল প্রফেসর লুই ক্রিস ইভান্স, তার নামে ইভান্স সিন্ড্রোম বলে। স্মার্ট সেল, দ্যাটস আ ভেরি ইম্পর্টেন্ট ফিচার্স অফ অ্যাটিপিক্যাল লিম্ফোসাইট। যখনই, কারণ সেলগুলো খুব মানে ডিন্যাচুরেশন বেশি হয়, যখনই আমরা স্মিয়ারটাকে, দিস ইজ আ বেসিক্যালি আর্টিফ্যাকচুয়াল সেল, যখনই আমাদের মানে সেলগুলোকে স্মিয়ার করা হয় এরকম স্মার্ট হয়ে যায়। এছাড়া এই সেলগুলো, দিস আর অল লিম্ফোসাইট, these are all lymphocytes. Within the CLL, the bone marrow lymphoid cell is more than 30%. Third point, third clinical feature, third criteria. Third criteria will be bone marrow lymphoid cell will be more than 30%. So of course the lymphoid cell should be more than 30%, and absolute lymphocyte count will be at least 5000 per, more than 5000 per cubic millimeter. এবং we have to identify the atypical lymphocyte. এগুলো সব স্মার্ট সেল দেখো, নিউক্লিয়াসের থেকে এই সেলের নিউক্লিয়াস আরবিসি থেকে অনেক বড়, রিলেটিভলি high amount of cytoplasm, coarse chromatin, no nucleoli, but there is an indentation. This is prolymphocyte. This is prolymphocyte. That prolymphocyte count will determine whether it is CLL, CLL PLL or PLL itself. ঠিক আছে, দেখে নাও। This is prolymphocyte. তিনটে জিনিস পাবে, ম্যাচিওর লুকিং লিম্ফোসাইট, বোন ম্যারোতে that count should be more than 30%, and peripheral blood smear at least and more than 5,000 absolute lymphocytesis, and smart cell 3, there might be anemia, might be thrombocytopenia, or it may present as Evans syndrome also. So if it is hemolytic anemia, so what will be the other kind of cell in RBC? There might be cystiocytes, there might be cystiocytes, there might be helmet cells, etc. etc. না pencil cell কেন থাকবে? Okay, and the third cell we have to identify this atypical lymphocyte. So other criteria of CLL আর কি হবে? আমরা ক্লিনিক্যাল ফিচার পড়লাম, পেরিফেরাল ব্লাড স্মিয়ার পড়লাম, বোন ম্যারো পড়লাম, বোন ম্যারো পড়িনি যদিও, বোন ম্যারোতে আরো অন্যান্য কিছু আছে। যদি বোন ম্যারো বায়োপসি করি, ইফ উই ডু দ্য বোন ম্যারো বায়োপসি ফর, আচ্ছা ঠিক আছে পরে গিয়ে অল্প হবে, if we do the bone marrow, atypical cells may present mainly in 4 sites in bone marrow. So according to the presence of that atypical cell, the bone marrow biopsy features can be classified into 4 categories. Okay, so bone marrow biopsy features or category of CLL might be nodular, interstitial, diffuse and sclerotic. কেন ইম্পর্টেন্ট কথাটা, কেন ইম্পর্টেন্ট? Remember, this diffuse type of bone marrow biopsy features of CLL having very worse prognosis, very worse prognosis. Okay, sclerotic type. Immunophenotyping, apart from CD5 and CD23, it might be positive for CD19 and CD20. B-cell হয়ে গেল। So this is mature B cell, and of course surface immunoglobulin of IgG heavy chain variant কেন বলছি তাহলে? Rearrangement of variable part of heavy chain is the causative causative pathological features of CLL. So surface immunoglobulin heavy chain variant should be found in CLL. Okay, so there are 2 important types, similar conditions like CLL. One is SLL and one is MBL. One is small lymphocytic leukemia, another is mature B lymphocytic leukemia. Small lymphocytic leukemia is a misnomer because there is no leukemia basically. Small lymphocytic leukemia is nothing but there is absolute new lymphocytosis, but the count is here is less than 5,000. Okay, but in case of MBL, the count is here is more than 5,000, similar to the CLL. It is positive for CD19, CD20, but it is not positive for CD5 or CD23. These are CD23 negative, CD5 negative. MBL, monocytic B-cell leukemia. Sorry, monoclonal B-cell leukemia. Monoclonal B-cell leukemia. The count is more than 5,000. CD19, CD20 is positive, but CD5 or CD23, either or both might be negative. এটার অরিজিনাল জার্মিনাল সেন্টার থেকে আছে, but the rearrangement, the mutation is not like CLL. So what are the mutations causing the CLL? ওই যে একটাই মনে রাখ at least, এই যে প্রোলিম্ফোসাইট, this prolymphocyte, presence of prolymphocyte itself is a very bad prognostic factor. It's a very bad prognostic marker, and this prolymphocyte is associated with trisomy 21. Yes, trisomy 21 is associated with presence of prolymphocyte, and it carries a bad prognosis, and of course it has a relationship with Down syndrome. Other than trisomy 21, deletion 13, one of the important features. 13q14, খুব ভালো যদি মনে রাখতে পারো 13q14, and deletion 17 also যদি মনে রাখতে পারো. These three important mutational factors associated with CLL. Bad prognosis নয়, এগুলো good prognosis, but trisomy 21 is bad prognosis. তাহলে যদি bad prognosis এর কথাই আসে, what are the features of worse prognosis? One, Richard syndrome. With the advancement of CLL, some of the cases, around 15 to 20% cases, Richard syndrome is the condition in which in advanced cases of CLL, some proportion of CLL cases they presented to the clinicians with the features of severe headache, bone tenderness, fatigue, fever, and sudden onset of lymphadenopathy. Because this CLL has been transformed into DLBCL type of lymphoma here, and DLBCL is a very high grade lymphoma. So this is Richard syndrome. Okay. Second condition associated with poor prognosis is presence of JAP17 expression. মনে রাখতে হবে না, জাস্ট এইটুকু নামটুকুই মনে রাখো, JAP17 expression. Third, immunoglobulin heavy chain rearrangement. Fourth, trisomy 21, that is presence of more than 55% of lymphocyte or PLL. And fifth is if the total, absolute lymphocyte count is more than 30,000. That's it, এটুকুই মনে রাখো।